Hello, everyone. Good evening. Thank you so much for joining us. We really appreciate it. It's nice to see everyone here. Just in the interest of time, I'm going to go ahead and get us started. So welcome to today's Project Echo, Ask the Experts, the role of immunotherapy in advancing the treatment of HCC and BTC. This is session 2 of 5, Emerging Evidence Regarding Immunotherapy for Immediate Stage HCC. I'm Sarah Bingle-McKillips. I'm with the France Foundation, and I'm the staff facilitator for today's session. And it's wonderful, again, to see all of you here, ready to hear the latest advances in HCC management. Just before we start, I want to take a brief moment to introduce Project Echo and explain the premise behind the meeting format of these sessions. Project Echo stands for Extension for Community Healthcare Outcomes. It's a global movement to share knowledge and expertise across distances. It creates a learning loop where all participants, including our experts and you, can learn from one another. Our sessions are designed to be interactive, so we really encourage you to make the most of this time by asking our faculty experts here any questions you have about HCC or what you see in your practice. Your active participation is what makes these sessions truly valuable. So again, thank you so much for being here. I'm really looking forward to a dynamic and informative session. And with that, I'll hand it over to Dr. Burgoyne to get started.
Thanks, Sarah, and thanks everybody for joining us this evening. So as Sarah mentioned, we're here to continue our 5-part series, moving on to session 2 today, which is Emerging Evidence Regarding Immunotherapy for Intermediate Stage HCC. And I'm really pleased to be joined by my friend and colleague, Dr. Zachary Berman, from interventional radiology. And we're also thankful for the planning committee, which you can see here listed on the right-hand side of the slide, that helps develop some of the content that we're going to be talking about today. So these are disclosures for myself and for Dr. Berman. All of these financial relationships have been mitigated by the France Foundation. And I would like to give some sort of special thanks to our educational support from an educational grant from AstraZeneca, as well as recognize the accreditation bodies that are helping to provide CME credits for today's content. So I'd like to dive right into kind of our objectives for today. So after engaging in this education, learners will demonstrate improved abilities to formulate a patient-centered plan for treatment of intermediate stage HCC while considering patient perspectives and disease status, develop strategies for effective multidisciplinary communication and coordination, and to describe the key results of clinical trials investigating novel immunotherapy approaches for intermediate stage HCC. So to get a sense of our agenda for today, as I mentioned, we'll start off with some introductions. As I mentioned, I'm joined by my colleague, Dr. Berman, who's from interventional radiology. I'm a medical oncologist. We work together at UC San Diego, taking care of our patients with liver cancer. So hopefully we can go over some of the basics about how to recognize intermediate stage HCC today, talk about treatment approaches for intermediate stage HCC, including local regional therapies, the emerging role for how we're thinking about adding immunotherapy to local regional therapies, talking about some of the clinical trial data that's emerging to support that strategy. And then we're going to finish today with some multidisciplinary tumor boards presenting and discussing some patient cases, either cases that you all have that you want to bring to the table that we can review, or we do have some cases that we can go over from the slide deck as well. So before we launch into our discussion today with content, I want to get a bit of a sense on everybody's baseline knowledge with the pretest question, which is which of the following best describes results of the ongoing EMERALD-1 trial, which is assessing combination therapy with TACE and immunotherapies in hepatocellular carcinoma. And the choices are A, adding a CTLA-4 inhibitor, but not a PD-L1 inhibitor, improves progression-free survival over TACE alone. B, adding PD-L1 and CTLA-4 inhibitors improves PFS over TACE alone. C, adding PD-L1 and VEGF inhibitors improves PFS over TACE alone. Or D, adding PD-L1 and VEGF inhibitors has no effect on PFS over TACE alone. So I'll give everyone a moment to answer that question. If you want to use the QR code on your screen. Okay, well, hopefully everyone's had enough time to answer that pretest question. And with that, I'm going to turn things over to Dr. Berman to teach us about intermediate stage HCC.
Thanks so much, Dr. Burgoyne. Like you said, my name is Zach Berman. I'm an interventional radiologist at UC San Diego. I have a particular interest in liver malignancies, particularly hepatocellular carcinoma. It's become a huge passion of mine, and kind of exploring how we can make therapies better. But in order to make it better, I think we need to understand kind of where we're starting from. So could we go to the next slide? Like most malignancies, the NCCN is, a great way of, starting to understand of what a disease process is, how we think about treating it, what are the principles of therapy, and et cetera. So usually that's where I like to start. And so looking at the most recent guidelines from 2024, once HCC is confirmed, which is either via imaging, when being probably the only malignancy that I know of that's confirmed by imaging only without a pathology diagnosis, though sometimes we do a biopsy. The first thing is they recommend a multidisciplinary evaluation. And I think that goes, from, top to bottom, both with people who do local regional or systemic therapies, but then also considering the patient at a whole, like a hepatologist to look at the whole disease process of cirrhosis, which in the US is the most common etiology of HCC. And then once you have that, you can then, differentiate your patient into lower disease burden, thinking about curative intent therapies such as transplant or resection, and huge pipelines directing them towards that. Then we also have the extrahepatic metastatic disease patients, bunch of randomized controlled trials, pivotal trials more recently, very clear directions to go for them. But unfortunately, today we're going to be stuck in the gray area, which is liver confined, unresectable, ineligible for transplant for whatever reason, is almost always our BCLC-B patients. Next slide, please. So what is the BCLC staging system? I'm sure they talked a little bit about it at the previous one, but please bear with me looking at it again. We look at, mainly three different phases. You have the early stage, small tumors, relatively, decent in size, nothing too big, within Milan criteria and acceptable for potentially curative intent therapies, such as ablation or resection. Then, like I said, on the far right side, you have the advanced patients with portal venous invasion or extrahepatic disease, but still have a preserved liver function. Again, I think that's the next talk you guys are going to get, talking about advanced systemic therapies for these patients. And then you're kind of stuck with intermediate. And what I always find the funniest about this BCLC diagram, which you see in almost every single one of these talks, is it's the intermediate stage B is always the smallest section physically. Like if you look at the space inside of this chart, where if you look at the patients, it's by far the biggest subgroup of patients and the most heterogeneous subgroup of patients, and really can be some of the most challenging patients for us to treat, either from a local regional perspective or from a systemic perspective. And so as you go to the next slide, it's super important to understand that BCLC-B, even though it's such a narrow slice on the diagram, it's a very large and heterogeneous population of patients. You have all the way from two very small tumors, which are very easily treated with local regional therapies, to kind of diffuse multifocal bilobar disease, which, it's, in my opinion, a slam dunk. They're not going to benefit from local regional therapy. And then everything in between. What do you do with the patient with 3 tumors or 4 tumors or 5 tumors? What if they have one big tumor and like 3 other small tumors? Technically, that's all BCLC-B. And you could have very, very different treatment recommendations. And so, Dr. Burgoyne and I just finished our own tumor board a few minutes ago. And if you look at our discussions, early stage disease, super easy. Make a decision, next patient. Advanced disease, again, very easy decision, next patient. We spend most of our time in tumor board discussing the BCLC-B patient because it can be so challenging. In order to make it less challenging, there have been a number of subclassifications that have been created. This is just one of them right there. Some of them, like a Hong Kong staging system, et cetera, like to divide it up into different subgroups, subgroup 1, subgroup 2, and subgroup 3. I think ultimately the important part is that we're going to start to think about which patients are going to benefit from local regional therapy, which patients are going to benefit from systemic therapy, and then kind of the messy in between is, as we'll talk about in a little bit, probably patients you could benefit from both local regional and systemic therapy. And I think this is an area of active interest for a lot of research and clinical trials, and we're going to see a lot more over the next decade or so advancing this. Next slide, please. And I think most people perceive, and at least I perceived when I first started treating patients with HCC, is that it's a linear progress as you go through the BCLC guidelines, right? You start at the very left, you have your early stage disease, maybe we do a little local regional therapy, maybe you have a resection, etc. Then you have multifocal recurrence, and then you do some TACE, and then eventually you get a metastatic disease, now you're doing systemic therapy. I think in today's day and age, we're starting to see that is not just a linear one-way street, right? You don't go from your early stage to your systemic and that's the only direction. We're seeing a lot of patients now who are doing well on systemic therapy to the point where we can now do local regional therapy. Maybe they've had such shrinkage of their tumor that they would benefit. And now we can kind of cytoreduce them that way. And I think, when we start to see a lot of this data, this kind of like proves it, right? So this is a study, and I think this is just a representative study of a lot of studies that are out there now, showing that if we get great responses with either systemic therapy or local regional therapy, in this case, both, that we can get them to a curative intent therapy, whether it be resection or transplantation. You can see that the overall survival is significantly better than whether we get them to just destination systemic therapy with local regional therapy. I think for a lot of IRs out there, that's kind of intuitive. We live in the realm of patients getting local regional therapy as either downstage or bridge to transplantation. I think, in the past with systemic therapies, that probably hasn't been the case when it was sorafenib and very few patients getting there. But some of the more novel immunotherapies that we have, we're seeing more and more patients get to the possibility of having a curative intent therapy. Dr. Burgoyne and I, for instance, last week had a patient get transplanted who had, an aggressive tumor that we did TACE combined with immunotherapy, and he had a near complete response and, ended up getting a transplant. Maybe 10 years ago, that's probably not heard of, but we're getting to that point now where we can offer patients better overall survival and progression-free survival by getting them to curative intent therapies. Next slide. And so now that I've kind of laid that foundation, I think it's important that we talk about different approaches and kind of start to talk a little bit about how immunotherapy might play a role in intermediate therapies. Yes, thanks. So again, going back to the NCCN, which is always a good place to start. If we look at that kind of messy middle of the liver-confined, unresectable, non-transplantable disease, for whatever reason, in my experience, it's most likely they're out of Milan criteria, which is what our transplant center uses for candidacy. You have a whole bunch of local regional therapies that we're talking about, and then systemic therapies, and then obviously clinical trials as well. And then we can see how they respond. We'll see if they either are able to be downstage to a curative intent therapy, or if we need to, consider other different types of therapies. And again, the goal, as I think all of us have, is at least initially, if we can get them to a curative intent therapy, we should. Next slide. And so when we start talking about these therapies, I think it's incredibly important that we understand the timeline of how all of these therapies came to be. Because, at least when I first started this, I didn't realize the robust history of a whole bunch of different therapies that were offered. So the very first therapy was offered in the early 1940s, which was external beam radiotherapy. They obviously didn't have the modern technology that they do now. So that quickly showed to not be as effective as we were hoping it to be, which led to about the early 1970s. In Japan particularly, they started to realize that if you were to do hepatic arterial embolization, particularly with chemotherapies and gelatin sponge, that patients were actually having good responses. And by good response, the 1-year overall survival was 50%. So just to give you a sense of where we were starting in the 1970s and 80s. Things kind of stumbled and bumbled along since then until about the early 2000s. There were two seminal randomized controlled trials comparing chemoembolization to best supportive care, which were both positive and showed that there was a survival benefit from us tackling local regional therapies, the tumors local regionally. And that's when TACE really became the standard of care for these patients. Right around the kind of 2007, 2010 region, we saw the first systemic therapy, sorafenib, get its benefit shown in clinical trials with an overall survival benefit. But really, things didn't explode on the systemic arm until the kind of adoption of immunotherapy, initially with ipilimumab and then tremelimumab, and then additional TKI agents around the same time too. And Dr. Burgoyne is going to talk a lot more about this as we go through, but really kind of the big trials came out when atezolizumab and bevacizumab first showed significant positivity over sorafenib as part of the IMbrave 150 trial, and then subsequently durvalumab and tremelimumab as part of the Himalaya trial. Again, I'll leave that to Dr. Burgoyne. Much more in my out of my realm of expertise, although in a past life I was probably a medical oncologist. I think what's interesting though is that a lot of this technology is not new. The initial, tear, which we think about as being kind of a new therapy, was actually predated TACE. It was actually a surgical procedure in the 1950s where they would actually go in and stick the hepatic artery surgically and infuse the radioactive spheres. And so even though we see it having like a coming to age moment right now, it's actually one of the oldest therapies that we have, which I always find interesting. Next slide. So when we talk about different therapies, you'll hear a bunch of different terms. Ablative therapy, which I think most people consider as percutaneous ablation, which is sticking the probe in under imaging guidance into the liver. The four main types you'll hear about are radiofrequency, which uses kind of oscillating magnetic fields in order to generate heat, and that's how it kills the tumor. That's kind of mostly been supplanted over the past 10, 15 years or so with microwave ablation for a variety of technical reasons, but it's able to do better ablations than radiofrequency. So microwave ablation is kind of the standard of care in most places. There's occasional uses for cryoablation, which uses freezing energy to freeze the tumor and then causes ice crystal within the cell, which pokes holes in the cell membrane. This is particularly interesting, in my opinion, as it has a potential role for synergy with immunotherapies because it leaves the proteins within the tumor intact, so you can have then presentation to the antigen. And I think even though we don't see a lot of cryoablation used in the liver now, I think going forward as more and more trials are coming out, you'll see it used a lot more. Irreversible electroporation is another novel ablation technology where it actually destabilizes the cell membrane by passing high voltage across it. We're talking on the order of about 3,000 volts. And we're seeing, again, for the same reasons that cryoablation might be adopted, it also leaves the cellular proteins intact. So you can then have it presented to the immune system for kind of maybe heightened immune activation. Then we go to our transcatheter, transarterial therapies. The big one is chemoembolization that you'll hear about. There's two different flavors of that. The first one is the chemoembolic agent, usually doxorubicin or some variant of that drug class, mixed with an oily substance called thiodized oil. That's called conventional chemoembolization, or drug-eluting bead, where the doxorubicin is actually soaked within the beads and is eluted over the course of a couple of days or so from the beads. There's various advantages and disadvantages to both. There was a trial that came out that showed there was a head-to-head comparison between the two that showed no benefit of one versus the other from an overall survival. However, the side effect profile from the drug-eluting beads were actually, it was much better tolerated. So that's become a standard in a lot of places. And then radioembolization, which is not necessarily plugging up the artery and closing it to kill it, but actually the idea is it's just brachytherapy, where you have a bunch of radioactive spheres into the tumor and it elutes the radiation over the course of about 2 weeks. Then you also have conventional and stereotactic body radiotherapy, where the radiation is beamed from the outside in. I think most people are familiar with that. Next slide, please. Again, TACE, as we talked about, the main way it affects its mechanism of action for cellular death is through ischemia. So you're plugging up the artery, you're cutting off the artery, the oxygen supply to the tumor, and at the same time too, you're also doing a double hit with chemotherapies. Usually, it's either doxorubicin, mitomycin C, and sometimes cisplatin is used as well. There's, like I said, no benefit of conventional TACE versus drug-eluting TACE. However, the drug-eluting bead TACE has fewer side effects. Y90 radioembolization or TARE, although it sounds very similar, like I said, it does not actually plug up the arteries. The arteries will stay completely open, which has its own advantages compared to TACE if you ever have to repeat your therapy. But its main mechanism of action is actually the radiation itself causing double-stranded DNA breaks. Next slide. For a while, we didn't know which one was better. I think if you look at the current guidelines, TACE has a predominant role. And I think that's because it was the first one to have a lot of the major randomized controlled trials. And so it has the most literature behind it. But we're starting to see over time, as more trials come out comparing the two, that TARE potentially has the benefit to be better. And so I think the big one was the TRACE trial, which came out a couple years ago, which was a randomized controlled trial looking at BCLC-B, most patients above the B, up to 7 criteria, and they were randomized to either DEB-TACE or TARE. The randomization only ended up having 36 patients in each arm. I think it's super important to know that this trial was stopped early at its first interim analysis, because you can see the overall survival benefit was doubled in the TARE arm. And so they couldn't ethically continue the trial, so it was stopped early. You can see large meta-analyses in this one, 17 trials comparing the two with over about 2,500 patients. Again, you can see the time to progression significantly longer in TARE. And depending on the patient selection, overall survival is no different between the two. The side effect profile from TARE is also a lot better. Some patients with TACE have to be admitted for post-embolization syndrome. No patient who has radioembolization has to be admitted to the hospital. It's entirely an outpatient procedure. Next slide, please. Again, we kind of talked a lot about this already. The biggest difference between TACE and TARE is that you do want your patients to be slightly more robust for TARE. It is a more effective therapy, and most trials were done in Child's PUA patients. So for that reason, you do want to have a slightly lower bilirubin cutoff. We use 2. Where TACE, you can go 3, 4, 8, even up to 5 in select patients if you're doing a selective infusion. But again, you want to have a slightly more robust patient. I really do think for patients with tumor vascular invasion, TARE is a much better therapy than TACE. And that would be another reason why you might choose TARE over TACE. Next slide. And then this concept of TACE failure, all patients will eventually fail TACE. The idea is that as you close up the artery, plug up the artery, the tumor is going to collateralize its blood supply, and you're going to get more and more and more exotic arteries feeding the tumor. Those arteries are not robust like the normal arteries that are inside of the liver, so it's harder to get your chemoembolic agent into the tumor, as much of the embolic agent as you'd want. So over time, TACE does eventually, the success eventually does become less over time. And obviously, the more and more and more you do this with less selective infusions, because there's less arteries going directly to the tumor, your chance of having decreased liver function increases. And so that's another reason why you might want to think of a therapy change over time. There's different prognostic scores you can use, and different classifications you can use for patients that may not benefit from just TACE up front. Next slide. And I think this is where I hand it off to Dr. Burgoyne for a little bit.
Thanks, Zach. That was a great overview of local regional therapy and all the tools that you have in your toolbox as a interventional radiologist. And as you mentioned, the focus of our discussion tonight is not just where we're at in terms of the local regional therapies that we have available as standard of care currently, but how we're moving towards the future. And immunotherapy has certainly revolutionized how we think about taking care of advanced patients, which we'll talk about more in our subsequent sessions. But as we're learning about how immunotherapy can be used in that setting, there's a real robust interest in bringing these types of treatments earlier in lines of therapies, including in the intermediate stage, which, as Dr. Burma mentioned, is quite heterogeneous and complex. So I think everyone's fairly familiar with the concept of immune checkpoint therapies in the context of the cancer immunity cycle. Really, this is a somewhat busy slide, but for the purposes of today's discussion, we'll primarily be talking about the anti-PD-1, anti-PD-L1 immune checkpoint, anti-CTLA-4 agents like tremelimumab or ipilimumab, and anti-VEGF agents like bevacizumab. And how can we think about the immune cycle in which we have antigen presentation, T-cell priming activation, tumor-directed T-cell trafficking and infiltration into the tumor, and then T-cell mediated tumor killing. And at what steps can we either abrogate these with a pharmacologic technique, or can we induce a pro-inflammatory environment with local therapies to have synergy between these two treatment modalities? So let's just talk a bit of baseline of, is this an either or an and question? And although the data in this space is not terribly robust, you can see that this is a real-world cohort study, as well as aggregate real-world data, looking at the concept of, is immunotherapy in the intermediate stage better than TACE and TARE? And I would say at this point, we really don't have strong evidence to support that. Certainly from some of this real world data, there's some suggestion that there is efficacy, certainly with the use of immunotherapy in the intermediate space, with the potential for a higher 1-year survival rate for atezo-bev versus TACE plus radiotherapy. Similar overall survival in this real world data shown on the right. And as I said, not a lot of robust evidence in this area. There are ongoing prospective studies that hopefully will help us gather more data in this space. A few select studies are shown on this slide. Atezo-bev versus TACE in intermediate HCC. This is an international ex-US phase 3 study. Local regional versus atezo-bev in patients with BCLC stage B, HCC, which is a phase 2 study. The REPLACE study, which is regorafenib pembrolizumab versus TACE-TARE in intermediate stage HCC. So interest in this space, again, of comparing systemic therapy, mostly immunotherapy, versus local regional therapy. But really, for the purposes of today's discussion, and I would say the most exciting data that's coming out of this space is this idea of combining the two therapies. So can we use local regional therapy, either TACE or TARE, to create immune microenvironment that will make immunotherapy work better? And why is that important? Like many tumor types, response rates to immunotherapy for HCC aren't as high as we would hope, typically in the 20 to 30% range. And we're hoping that we can have these complementary synergistic activities by combining the two therapies to help with antigen presentation and releasing the brakes on the immune system with a checkpoint inhibitor to see if we can get increased response rates and, of course, our overall goal of improving survival. So what's the evidence for this thus far of combining local regional therapy with systemic therapies? Without getting too much into the weeds of the studies shown on this slide, which you can see are other than the randomized study of sorafenib plus TACE versus TACE alone, which is becoming less and less relevant as sorafenib is no longer an agent that's in routine use, versus some of these real-world retrospective studies looking at various combinations of TACE with TKI or immune checkpoint inhibitors that showed that there was some preliminary evidence, at least in these real-world and retrospective studies, that we could see improvement in response and perhaps improvement in survival. So that has led to the development of some prospective studies, many of which are ongoing and close to being reported out or recently have reported out, which we'll talk about today. These key studies are shown here, EMERALD-1, which is the combination of durvalumab and bevacizumab, looking at the blockaded PD-L1 and VEGF in comparison to TACE versus TACE alone. LEAP-12, which is the combination of pembrolizumab plus lenvatinib versus TACE, plus TACE versus TACE alone, as well as various other combinations here, ipi-nivo, nivo, durva-tremi, lenvatinib, etc. So I want to highlight most of our attention to the EMERALD-1 study, which was the first really large global phase 3 study in this space to report out earlier this year. And the concept here was if we took patients that were in this sort of heterogeneous group of intermediate stage BCLC-B patients, so confirmed HCC, not amenable to curative therapies, no extrahepatic disease, good liver function, Child-Pugh A to B7, good performance status, ECOG 0 to 1, measurable disease, excluding high-level vascular invasion, and no prior systemic therapy or TACE. And if we randomized these patients to 3 different arms, and these were arm A, which was durvalumab in combination with TACE, followed by TACE plus bevacizumab, durva plus bevacizumab. Arm B, which was durvalumab plus TACE, followed by, arm A was durvalumab plus placebo for bevacizumab. Arm B was durvalumab in combination with TACE, followed by durvalumab plus bevacizumab. And then arm C was placebo plus TACE versus placebo plus placebo. So the primary endpoint of this study was looking at progression-free survival for arm B versus arm C, using blinded review with key secondary endpoints of comparing arm A to C, overall survival, quality of life, and then other secondary endpoints, including response rates, time to progression, PFS response using investigator versus central review. So the key here is if we look at this DB plus TACE, D plus TACE, or TACE, so durvalumab plus TACE, durva plus TACE, or TACE alone, you could see here that this key primary endpoint was met. So median progression-free survival of 15 months for the durva-bev TACE group versus 8.2 months for the TACE alone. And the difference between durva TACE and TACE was not significant in terms of its confidence interval and p-value, so 10 months versus 8.2 months. If you look at objective response rate, it's not surprisingly, we saw the highest response in the durva-bev TACE at 43.6% versus 29.6% in the TACE alone group. And then if we look at the time to progression, again, longest of 22 months in the durva-bev TACE versus 10 months in the TACE group. What about safety? The nice thing about these sorts of studies is, although they are novel in the combination of these agents, these are drugs and modalities that we have quite robust safety data on. And thankfully, we saw no new safety signals beyond what we would normally see with TACE or VEGF blockade or immunotherapy. And you can see here that the grade 3-4 treatment-related adverse events are shown here. A bit higher in the durva-bev TACE of 32.5% versus 13.5% for TACE alone. The number of patients that needed to discontinue therapy due to treatment emergent adverse events was highest in DB plus TACE of 8.4% versus 3.5% for TACE alone. And importantly, no treatment-related deaths in the DB plus TACE. So that's TACE. As Dr. Berman just mentioned, there are pros and cons to the use of TACE versus TARE. Here in the US, and certainly at our center for patients that are robust and fit enough, we are more often using TARE than TACE, given the improved outcomes that we've seen with that treatment versus sort of older school TACE therapies. So what is the interest here in combining TARE with immunotherapy? Well, certainly very high. Similar to the safety discussion that we were just having about the EMERALD-1 data, Importantly, early phase 1 studies demonstrated that combining durvalumab in this particular study with TARE did not lead to any new concerning safety signals, and again, some encouraging preliminary efficacy data. 18-month OS of 58.3%, the mean OS not even reached, mean PFS of 6.9 months, complete response of almost 30%, objective response rate of 83.3%. So better than what we would expect with immunotherapy alone. So certainly develop some hypothesis generating research to carry this further. There are really 2 large studies looking at the combination of immunotherapy with TARE, one of which is the Rowan study, which is a phase 2 single-arm multicenter study looking at the combination of TheraSphere with durvalumab and tremelimumab for HCC, and the Emerald Y90 study, which is another phase 2 single-arm multicenter study looking at the combination of TARE with durvalumab and bevacizumab, again, in patients with unresectable HCC amenable to TARE. So where's this led us now? Exciting data coming from Emerald 1 suggesting that at least in the earliest data cutoff that we see an improvement in PFS. We're remaining to be seen if that's going to translate into an OS signal. And then in terms of TARE, there is an international multidisciplinary consensus statement suggesting that combinations of TARE, radiosensitizing chemotherapy, VEGF inhibitors, immunotherapy are all feasible. And this is a space that we'll definitely need to watch closely as it continues to evolve, because there's a lot of ongoing studies in this space and potential for practice-changing studies to be reported up potentially very soon. And with that, I will turn things back to Dr. Berman.
Thank you. That was fantastic. So I guess let's talk about, we choose an option, whether we choose to go systemic therapy, local regional therapy, or both. We get an imaging, what happens next? So could we go to the next slide? This is an incredibly complicated algorithm, but hopefully I can summarize it in somewhat succinct forms. You have BCLC stage B disease. Let's say you start with TACE. You do 1 or 2 sessions of TACE. You either get a complete response or you don't. If you get a complete response, you image in 3 months. For the most part, if you do not have a complete response by the end of, maybe 1 or 2 sessions of TACE, as long as they're still well compensated, their child's Pew score is still good, their performance status is also still good, you can consider are they downstage a transplant? Obviously, then they should go for a transplant. But if not, then you can consider maybe cycling in different types of therapies. If the disease is stable and there's only a little bit of viable disease, maybe think about switching therapies. So if you did TACE, maybe switching over to TARE. And we've shown in some of our research that we've done in the past that you can have a high response rate, up in the 80-ish% objective response rate. If they have stable disease or, a lot of disease that we weren't able to treat, maybe you consider changing a different modality, whether it be a systemic therapy, radiotherapy, ablation, etc. And again, if they have progressive disease, you have to think about what type of progression have they had. Do they now have vascular invasion? Now we're thinking a lot more of the systemic therapy. Is it, they had a good response initially, but now they just have a new tumor that, is also amenable to local regional therapies and they're still well compensated? You can continue with additional local regional therapy. And pretty much, if I were to remake this slide, I would pretty much get rid of the entire bottom part of it and say, present at a multidisciplinary tumor board and kind of hash it out. Because you'll have everyone's kind of voice there and everyone can kind of say the pros and cons of both. We really don't have a ton of data to kind of guide. So having, everyone, content experts and, at the table and talking is super important. And so I highly recommend that. Next slide. So, kind of key points to keep in mind. Even though we do get with local regional therapies great response rates, if you were to look at the response rates for TACE from the Precision 5 trial, which is the trial that looked at the conventional TACE versus DEB TACE, you have an objective response rate of about 60 or ish percent. If you look at some of the radioembolization outcomes, you have a response rate of, higher, maybe 80 or, up to 100 in some trials. Percent of response rates. The problem is, since you're only treating one of the tumors with a background of cirrhosis, they're going to have recurrence. And so, continuing to look out for the recurrence is super important. The Rowan trial, which I think is, quite fascinating, is trying to say, if we take patients who potentially might have out of field recurrence that we didn't treat, give them immunotherapy, are we going to delay that time to progression? There's some evidence from the IMbrave 050 trial, looking at patients who had a resection or microwave ablation, that there might be a benefit from the addition of immunotherapy in that setting. But I think Rowan is the first trial that's going to try and show that in the intermediate stage patient undergoing radioembolization. And then again, the important thing to know with immunotherapy is that you might have pseudoprogression. It's very unlikely you're going to have pseudoprogression with local regional therapies, but having a tumor that looks like it's growing by imaging or even by RECIST criteria, but maybe the tumor markers that have gone way down, discordance there. It's always important to keep that in mind. Next slide. And so hopefully after that whirlwind, well, I guess it already kind of gave you the answer, but we can come back to the question that Dr. Burgoyne started off with, which is, which of the following best describes the results of Emerald-1, which assesses the combination of TACE with immunotherapies. And as Dr. Burgoyne mentioned, it's the addition of the PD-L1 durvalumab with the VEGF inhibitor bevacizumab, improves the PFS over TACE alone. Again, we're still waiting to see OS data. That's not mature yet. Next slide. And so let's do some case examples.
Does anyone have a case that they would like us to review today from your practice? If so, don't be shy. It's a heterogeneous group, so we're happy to walk through it if someone has something to talk about. Otherwise, we can start with an example that we have. So when we're thinking about presenting our cases at Multidisciplinary Tumor Board, there's a number of factors that come into play that we think about, but when I'm posing a question to Dr. Berman, we think about why local regional therapy, which local regional therapy, when should we be thinking about immunotherapy? When should we be thinking about immunotherapy in combination with local regional therapy? Why would we choose immunotherapy over local regional? And what would the addition of immunotherapy provide? And then after we kind of make that selection, not forgetting to reassess for treatment response, bring that patient back to Multidisciplinary Tumor Board and kind of decide on next steps. So those are the things we're going to try to keep in mind for the cases we're going to talk about today. So Zach, you want to kick us off with case one?
Sure. Let's talk about Mr. Riggs. He's a 59-year-old male. He has a biopsy-proven cirrhosis with a history of HCC. He had resection of 2 3.5 centimeter masses a couple of years ago. He was on surveillance and then was found to eventually have recurrent tumors, kind of in the same territory of the resection. He's relatively, well compensated. He's Child-Pugh A. He does have a performance status of 1, which is something to consider. And our imaging shows 2 masses that are moderate in size at 4.2 and 4.6 centimeters, both within segment 8. He has no evidence, at least on imaging, of portal hypertension. And so I guess, how would we approach this case? So for me, or the way I think about these types of cases is, do I think local regional therapy is going to be successful? And for me, means successful is we can do 1 or 2 procedures and then hopefully get him back to being on surveillance. Going back to every 3-month imaging, not needing additional therapies, not having to come in every single month. Dr. Burgoyne and I always used to joke that some patients would get 12 TACEs, in the past, and I don't think those would be great patients for local regional therapy. So for me, when I see 2 tumors, even though it's technically BCLCB, I can see they're in the same segment. They're both in segment 8, which I start to think, okay, can I get to an ablative therapy? The 2 ablative therapies that I have are percutaneous ablation, which we talked about, microwave ablation, and ablative radioembolization. And so with percutaneous ablation, given inherent technology issues that it has, I can't do tumors greater than 3 centimeters, or at least I shouldn't treat tumors greater than 3 centimeters with that modality. And so I started to think about ablative radioembolization. This guy is Child-Pugh A, so he has preserved liver function. He's got a decently good performance status at 1. I think he could tolerate a selective radioembolization, and given that they're both in segment 8, I think I can do that. That's how I would approach this case. The sizes don't bother me as much. So I guess, Dr. Burgoyne, would you offer immunotherapy to this patient?
Yeah, it's a good question. And, as you mentioned, this intermediate group can be quite variable. As you noted, anatomically, these 2 lesions, and there are only 2, are in sort of the same spot of the liver. So although immunotherapy would not necessarily be a wrong choice, generally I agree with that approach of what can we do to get this patient the most efficacious therapy. And although unlikely that this person could be cured, what's the longest sort of disease-free interval that we can provide this person? And generally speaking, when I have an IR that I trust, like Zach, I know that he's not going to do a procedure just to do a procedure. He's going to do a procedure because he feels like it's in the best interest of the patient. So if Zach tells me, hey, I think this is a really good candidate for TARE, I think we can really get good tumor control, there's no obvious reason not to do it. Typically, we would reserve systemic therapy, reserve immunotherapy for the future. As we are expanding the number of modalities and how we use these modalities for HCC, patients are living longer. We don't want to burn through all of our bridges when we don't need to. And maybe this person will have a year or 2 years, and then they'll develop a lung met, or they'll develop tumor in vein, and they'll need systemic therapy. We'll have that in our back pocket. We may have something better in our back pocket in 2 years. And although the data that we just discussed for Emerald-1 is exciting, a few things to keep in mind. Number 1, it's TACE plus immunotherapy. So I think Zach would agree that TACE would probably be an inferior type of local regional therapy for these kind of tumors. So if we want to be strict evidence-based medicine practitioners, although this person could have potentially participated in Emerald-1 with this kind of tumor burden, this is not yet an approved regimen, and we don't have an OS benefit yet. So we have this exciting PFS number. And then what I'm really interested to see is, what will our data look like for combining TARE with immunotherapy? Outside of a clinical trial, I wouldn't offer it to this patient, but I think that in the future, that may be an area where we are thinking about combining those treatments earlier.
Yeah, I agree completely. I think that would have been a perfect patient, given that he did have 2 tumors grow relatively rapidly for a combination of TARE and immunotherapy in a clinical trial. And then hopefully when we do this discussion 4 or 5 years from now, it'll be standard of care, but not there yet.
Exactly. So I think we highlighted most of these points here on what we're thinking about with this person. This is not a de novo presentation. This person has recurred after prior resection. That does make us think a bit differently about the disease biology of this patient. Of course, as we are presenting at Multidisciplinary Tumor Board, we always actually start our tumor board talking about our patients that are eligible for transplant. That's always our goal, is to get someone to curative therapy if possible. So re-resection, transplant, ablation. So if someone fits within those criteria, we're always considering those things first. And as Zach mentioned, it's that large group that tends to fall in the middle that we do struggle a bit with what to do. So I think we talked about advantages of TACE versus TARE. And then we can never undersell from NCCN or our own academic practices. HCC still is a relatively rare tumor type. We're still trying to learn as much as we can about these patients. So particularly a patient like this that has good liver function and a performance status that would probably allow for participation in a clinical trial. If a trial is available, always to try to get our patients enrolled, because those are going to be often the best chances for a good outcome. Any questions on this case? So I guess we have follow-up here. So Zach, you want to round us out?
Yeah. He's interested in enrolling in a trial, but he has questions of what to expect and next steps. How would you proceed? I find this, particularly if we're looking at clinical trials with a combination of both local regional and immunotherapy, to have both people doing it in the same clinic. So Dr. Burgoyne and I have the same HCC multidisciplinary clinic together. And so we can actually see our patients together. So, there's a lot of questions about immunotherapy that I can't answer. There's a lot of questions about local regional therapy that Dr. Burgoyne can't answer. And so it's super helpful that if you can see the patient together, you can help answer all of the questions that they have as it relates to complex clinical trials. I don't know what your experience has been.
Yeah, I think that that's a great point. And I mean, we're very fortunate that we can have our multi-D clinic together. I think it helps a lot with taking care of our patients who sometimes are under-resourced, and it can be challenging for them to get to multiple visits. And incorporating those factors in our decision-making as well. Someone that lives in the desert that is only interested in coming in for like a one and done procedure, probably local regional therapy alone is going to be in their best interest. Someone that is highly motivated, very interested in participating in clinical research, very interested in sort of doing everything that they can, would be a good candidate for a clinical trial. But everything that we do does have risk as well, right? So, always making sure that we're not including patients that, would be higher risk due to frailty or other medical problems, other autoimmune conditions that would preclude the use of immunotherapy, et cetera. Okay, we have 7 minutes. I think we can probably do one more case if we do it quickly. I can kick us off. So this is Ms. Rhodes. She's a 53-year-old woman, history of obesity, hypertension, dyslipidemia, prediabetes, comes into the ED, severe right upper quadrant abdominal pain. She's had some discomfort for several years. It's been worsening over the past few months. No history of hepatitis or alcohol use disorder, imaging in the ER, and her admission that followed showed an enlarged liver on abdominal ultrasound. A CT abdomen with contrast showed a suspicious discrete mass in the right lobe of the liver. And on a follow-up multiphasic MRI of the liver showed that mass was quite large, 11 centimeters predominantly in the right lobe. So she ends up undergoing a biopsy, which confirmed she has metabolic fatty liver disease without cirrhosis. She has child-Pugh A, good functional status. And then radiology reports this consistent of her mass that is LIRADS 5, which is diagnostic for HCC. So where would we think about taking this patient with a right-sided 11 centimeter mass? Zach, what do you think?
We don't get to talk about this a lot, at least in an American tumor board, although I imagine Asian tumor boards where they have a much higher prevalence of hepatitis B and not so much cirrhosis as we deal with. But she doesn't have cirrhosis and likely doesn't have portal hypertension either. So I would actually ask our surgeons first off whether they think this mass is resectable. Because as much as I have all of my fancy toys, and you have, all of your fancy immunotherapies, I think this patient would be best off with resection if feasible.
Exactly. So the things we would think about for this patient, it is a large mass, but depending upon liver volumes and resectability and a formal evaluation by our surgical team, that's not always necessarily something that precludes safe resection. And, thinking about ablation, really much larger than we would think about for ablation to be effective. And then always thinking about transplant candidacy as well. So it is a localized tumor. Obviously, we want to finish our staging workup for some and all of our patients, but especially those that are going to be higher risk of metastasis with a large mass like this. So we would get a CT chest that showed no evidence of metastatic disease. And then an alpha theta protein, which was quite elevated here at 65,000. So Zach, if our surgical colleagues said not a good candidate for resection, what would you think about for her for local regional therapy?
Yeah, the tumor size itself, I think radioembolization is going to be much better than chemoembolization, not only from a efficacy standpoint, but I think the toxicity standpoint, it's going to be much better tolerated. I think the only thing that really gives me pause and hesitation here is an AFP of 65,000. Now that could just be from that very large tumor that she has. But obviously you're worried that there may be metastatic disease that we just can't see, even though we did do a complete a workup looking for that. So I think, seeing that and the size of the tumor, I think, at least for us, I would look to you and see if you have any, guns in your tool belt.
Yeah. Again, similar to our last patient, if this is a localized tumor in a finite anatomic region that you felt like you could tackle with TARE, there was no vascular invasion, no clear evidence of extrahepatic spread to lymph nodes or distant mets, probably first crack of TARE, I think would be very reasonable for this patient. But again, with that AFP being quite elevated, really want to watch this patient closely, getting good follow-up imaging quite quickly after that first tear, maybe even as early as 6 weeks. Not so much for assessment of the response to the tear, because that would be a bit early to really determine residual viable tumor versus radiation effect, but making sure other disease wasn't blossoming, because we don't want to wait too long before introducing systemic therapy if it's going to be needed. And then again, for ongoing clinical studies, particularly those combining TARE with immunotherapy, I think that would be a good potential option for Ms. Rhodes as well.
Yeah, and speaking to your previous point, I've really you see the AFP response a lot sooner if you do local regional therapy, a lot sooner than you'll see an imaging response. And so maybe a month later, you might repeat the AFP. And, we've seen some dramatic responses with radioembolization where, even normalization from an AFP of 65,000 is not unheard of. So if we were to repeat the AFP and it was going up, or maybe it stayed the same, then we're going to do our imaging a lot sooner, because I'd be worried about that.
Exactly. Well, I think that brings us pretty close to time at 6:59, and I know Sarah has a few closing comments, but I just want to say thanks to everyone for your attention tonight. This is an area that we're very interested in. Watch this space. It's evolving rapidly, and we hope to continue to make advancements for our patients with intermediate stage HCC as we learn more about how to combine immunotherapy with local regional therapy.
Yes, thank you so much, everyone. It's so nice to see you all this evening. Definitely put some questions in the chat. I'm just going to wrap us up, but feel free to ask any questions that you have. On the screen here are some QR codes for claiming your CME and submitting your evaluation. I will also email this out to everyone who's in attendance here. Also, part of our program here is developing an action plan. So it really helps you reflect on the teaching points from today's session and how you're going to incorporate them into your practice. So it's a really great tool for you to check out. And if you go to any of our future meetings, it'll follow you along the way. We'll email it to you every time. And speaking of future meetings, we do have more monthly. There's several dates each month from now until December, and we'd love to see you at our entire HCC and BTC curriculum. So again, if you can't get the QR codes, I will send them off an email to everyone this evening. And thank you so much for coming. It was a pleasure to see you all.